Good morning, everyone. Welcome to this week's Thyroid by MD's webinar. I'm Camilo Gonzalez Velasquez, co-host of the Thyroid by MD's webinar series, and today we're honored to have two distinguished guests with us for an engaging and insightful discussion. First, we have Dr. Aradhya Nigam, who will be presenting his group's recent publication titled Tumor Grade Predicts for Calcitonin Doubling Times and Disease-Specific Outcomes After Resection of Medullary Thyroid Carcinoma. Dr. Nigam is currently a surgical resident at Georgetown University and is set to join Memorial Sloan Kettering Cancer Center in New York as a surgical oncology fellow. His research focuses on understanding and developing novel approaches to treat difficult-to-treat tumors, particularly medullary thyroid carcinoma and other neuroendocrine tumors. Joining him, we have the great honor of having Dr. Margaret Brandwein-Weber, a friend, Thyroid's very own thyroid pathologist, rock star in the field, Chief of Pathology at Mount Sinai West and Director of Head and Neck Pathology Fellowship. Dr. Brandwein-Weber has served as President of the North American Society of Head and Neck Pathology and has been an active participant in the World Health Organization's classification of head and neck tumors consensus committees. She's had an extensive publication record with over 130 manuscripts, 50 book chapters, and 3 single-author textbooks on head and neck pathology. Dr. Brandwein-Weber is also an investigator in an NIH-funded project focusing on oral cancer outcomes and biomarkers. We are privileged to have such esteemed experts with us today, and we look forward for their presentation and obviously a very interesting discussion. Before we go on, I would like to encourage our audience to please send any questions that you might have through your Q&A function, and we'll try to get to as many of them by the end of the hour. So without any further ado, I will hand it over to Dr. Nigam to present his research.
Good morning, everyone. My name is Aradhya Nigam, and as Dr. Gonzalez alluded to, I'm a resident at Georgetown, and will be joining Memorial Sloan Kettering for a surgical oncology fellowship this August. I wanted to begin by thanking everyone for being here, and for Dr. Gonzalez for moderating this session, and Dr. Brandwein for being our expert discussant and taking the time to do so. I also wanted to thank the Thank Foundation for providing a platform to present our research entitled Tumor Grade Predicts for Calcitonin Doubling Times After Curative Resection of Medullary Thyroid Carcinoma. This work is a culmination of an international effort to develop a new grading system for medullary thyroid carcinoma in order to better predict outcomes and change management for patients with more aggressive versus less aggressive medullary thyroid carcinoma. And our group's push was to develop clinical applications for the novel grading system. So I just wanted to go ahead and begin by thanking my mentors, including Dr. Unch, Dr. Gosain, Dr. Shaha, Dr. Wong, Dr. Tuttle, Ganley, and Spanheimer, as well as Dr. Chu for helping me develop this grading system and developing some surgical clinical applications. We have no disclosures that I know of. To take a step back, just to orient everyone, medullary thyroid carcinoma is the most common, third most common thyroid carcinoma in the United States. It's a neuroendocrine tumor that arises from the parafollicular C cells and has an incidence of about 1,000 cases per year. The C cells themselves produce calcitonin, which plays a major role in calcium homeostasis by inhibiting osteoclast activity and inhibiting renal absorption of calcium. But for our project itself, calcitonin is actually a very important diagnostic and prognostic marker in medullary thyroid carcinoma. Not only is it used for an adjunct lab to diagnose medullary thyroid carcinoma, it's also used in the surveillance setting, which is the crux of our work and current project. Surgery currently represents the only curative treatment option for patients. While things are currently in development, surgery remains the major form of treatment. However, despite surgical resection, recurrence remains fairly high at about 50% of patients despite resection. So there's been a major effort to try to stratify or determine factors that predict for the majority of those 50% of patients that recur. And while tumor staging has been prognostic for survival, it's obviously the higher the stage, the decreased rates of survival. There's been a great push, especially previously by our group, to try to develop a nomogram or factors that are associated with worse outcomes, including recurrence and survival. And this led to a paper that came out by Dr. Ganley in 2015 that highlighted preoperative factors associated with worse outcomes. And that included not only stage itself, but also peripheral vascular invasion, post-op calcitonin levels, the gender of the patient, as well as age. However, they did acknowledge in that paper that several factors were omitted, including acknowledging for calcitonin doubling times, as well as the mutation status of the patient. And as we know now, over the development of the last few years, mutation status plays a very critical role in predicting for outcomes in patients, where about a quarter of patients do carry a germline RET mutation that varies with the risk and predicts for advanced stage and outcomes, with the highest risk patients definitely being 918 patients, arguably as well 883, but also high risk patients include codon 634 codon mutations. So while these are great for predicting outcomes in the preoperative setting, what we found is that due to a lot of work from the pathologists at Memorial Sloan Kettering, but also internationally, is that we could also predict outcomes based off what we knew in the postoperative setting, particularly histologic grading, which was developed as a prognostic factor to predict recurrence and survival in patients that had undergone resection. And so to better stratify patients, through an international effort, the histologic or the International Medullary Thyroid Carcinoma grading system was developed. It was first born out of our group back in 2020, which looked at mitotic index as well as necrosis, which was found to be highly prognostic and highly predictive of outcomes in patients. However, through an international effort, a two-tiered grading system was developed. And it not only included necrosis and mitotic index, but Ki-67. And through this effort, every single pathologic slide that was available was reevaluated for these specific factors, and different tiers and grading systems tested and evaluated. And the most predictive and most accurate and easiest way of stratifying patients was this two-tiered grading system. And in particular, the presence of necrosis and mitotic index greater than 5 and a Ki-67 greater than 5% was highly predictive of worse outcomes in patients diagnosed with medullary thyroid carcinoma. And the outcomes that were specifically looked at were local recurrence-free survival, distant metastatic-free survival, disease-specific survival, as well as overall survival. In this paper, we went on to evaluate, based off this grading system, what were the actual outcomes amongst patients. And right off the bat, you could see that across the board, by stratifying these patients into high grade versus low grade, you could see worse overall survival, disease-free survival, local recurrences, as well as distant metastatic rate. And so that got us thinking, if high-grade patients were associated with worse outcomes, what could this do in terms of surveillance? And we came across this paper, which is very, very well known, and was born out of the Machens group, which looked at CEA and calcitonin doubling times in medullary thyroid carcinoma. And calcitonin and CEA, as I talked about earlier, are validated biomarkers, which have been acknowledged in the ATA guidelines for detecting recurrence in medullary thyroid carcinoma. Its use is variable, its predictiveness is variable, it's especially CEA, it's a very poor specificity, and its correlation with progression or survival is still in question, but still for the most part, they are validated biomarkers that allow clinicians to predict for recurrence and poorer outcomes. And even to the point where the ATA guidelines advocate for the calculation of both calcitonin and CEA doubling times. And the doubling times themselves, while the absolute values are more variable, have been associated with recurrence and survival. As you can see in the graphs to the right, both CEA and calcitonin, if the doubling time for a patient is less than 2 years, it's particularly associated with worse outcomes. And it actually stratifies by the length of doubling time. So the lower the doubling time, the associated worse outcomes. And doubling times less than 2 years have been the marker for worse outcomes that have been accepted across the board. So the question for us was, if high-grade patients have worse outcomes and patients with lower calcitonin doubling times have worse outcomes, could high-grade patients be associated with lower calcitonin doubling times? And what happens when we combine the two factors? Could we identify a higher risk cohort? So the question in this manuscript was, does grade correlate with calcitonin doubling times and CA doubling times? And what are these subsequent effects on specific disease-specific outcomes, including local recurrence, survival, and distant recurrence? And the implications of the study, I think, are very powerful. Not only do we have the nomogram for preoperative prediction of patients, but we have the actual tissue in the postoperative setting to try to predict patients and their outcomes. So after a thyroid gland has been resected, we could stratify patients based off the necrosis, mitotic index, and Ki-67. And this subsequent analysis, which is an objective rather than a subjective kind of marker, could predict for surveillance strategies, could predict recurrence in patients, could predict for worse outcomes. And in particular, could we identify a particularly high-risk cohort of patients that do worse? And if we identify this high-risk cohort, could we change management options for patients? Could we change the way that low-risk versus high-risk patients are surveyed? And try to do the best for patients. So the study design of this specific manuscript was, we aim to evaluate the effect of grade on calcitonin and CA doubling times. And so we evaluated all of the specific patients at Memorial Sloan Kettering. And the reason we looked at Memorial Sloan Kettering is because we knew the follow-up intervals for patients. And we had a fairly good surveillance scheme for patients that was institution specific. And so we came up with about 117 non-distant metastatic medullary thyroid cancer patients that were stratified by grade, with 22 of them being high grade, 95 of them being low grade, with the last chart review being December of 2021. Median follow-up for the whole cohort was about 60 months. And so after stratifying patients into low grade and high grade, we aimed to question what the differences in calcitonin and CA doubling times were, particularly between high and low. And then we aim to also evaluate some specific disease-specific outcomes, as I alluded to earlier. Just to go into how we calculated the calcitonin and CA doubling times, in our institution, in line with the ATA guidelines, post-operative calcitonin levels are evaluated 6 months, 12 months, and then every 6 months, if applicable. So that was the perfect setup to be able to try to calculate very accurate doubling times in patients. And so we used the Kuma Hospital doubling time calculator, which the reason we used is we could have done it on our own, but it was just a very user-friendly platform where we could just input the date and the specific value. And not only did it graph out the doubling time, but it told us specifically what the calculator or modeled doubling time was. But the rule we had is that there had to be at least 3 successive levels to be able to model and calculate the doubling times. Sparse or high interval or intermittent interval patients we felt were less accurate. So we tried our hardest to try to find at least 3 successive levels. And after those 3, any sort of interval would be allowed for. Patients that remained undetectable, which is very common in low-grade patients, or had levels that never doubled over the study period, were designated as never doubled, and they actually weren't included in the doubling time evaluation. So the values you'll see are actually just patients that doubled over time. And before I get to those results, I just wanted to reevaluate our cohort of patients and just highlight what the differences are between low and high-grade patients. And in particular, you'll see that, especially when you look at the histologic evaluation of low-grade versus high-grade patients have present with worse stage. They are more likely to have extrathyroidal extension, a greater tumor size, lymphovascular invasion, as well as lymph nodes present at the time of surgery, which just highlights how aggressive these tumors are. You will also note that the preoperative CEA and calcitonin levels, while they are higher in high-grade patients, they were not statistically significant just because of the wide variability or wide range in calcitonin levels between low-grade and high-grade patients. And that just kind of attests to our study where absolute values of CEA and calcitonin levels are probably less prognostic, and it's probably better to measure CEA and calcitonin levels over time to try to calculate a doubling time. So on to our primary outcome, which was calcitonin and CA doubling times in high versus low-grade patients. I just wanted to begin by, while the doubling times are highlighted here, I think the more important bit is the breakdown of doubling time, where you'll see right off the bat, about 70% of low-grade patients never doubled compared to about 5% of high-grade patients. And that was true for both calcitonin and CEA, where about 70% of low-grade patients never doubled compared to 27% of high-grade patients. Now, when we looked at doubling times themselves, keep in mind that the doubling times did not include the values of patients that never doubled, just because it just could not be calculated for. But you could see vast differences in the calcitonin and CEA doubling time between high-grade and low-grade patients, with a median doubling time being about 8 months for high-grade patients compared to greater than 30 months for low-grade patients, demonstrate these significant differences. And then amongst the patients that had a doubling time less than 2 years, the top two kind of rows here, about 77% of patients were high grade. So among most of the patients that had a doubling time were high grade patients. So that led us to evaluate some of the outcomes amongst patients. So in particular, why does this per se matter? And the first kind of analysis we did is we did a multivariate analysis comparing outcomes between high grade and patients that had rapid calcitonin doubling times. So we compared high grade to low grade patients, and we compared patients that had calcitonin doubling times less than 2 years to those greater than 2 years. And across the board, we could see that high grade patients were associated with worse local recurrence, distant metastasis, as well as overall survival. And these hazard ratios are quite significant and very predictive of outcomes. When we compared patients that had a rapid doubling time compared to those that didn't, we saw that the distant metastasis rate was the only significant factor, predictive factor, and associated factor in patients that had a rapid doubling time. So then we went on to question, what if we could have identified this high-risk cohort of patients? So what if we combine rapid doubling time with patients that had high-grade tumors? Could we predict for this high-risk cohort of patients that need particularly very close surveillance? And so we did log-rank testing using a univariate analysis. And this is just comparing patients that had rapid calcitonin doubling times, in particular, those less than 2 years. And so what we did was we compared the high-grade patients that had rapid calcitonin doubling times to those low-grade patients that had rapid calcitonin doubling times. And so what we've went on to see is, in particular, for local recurrence and overall survival, high-risk patients with rapid doubling times had significantly worse outcomes. However, when it came to predicting for distant metastasis, in line with our previous Cox proportional hazard modeling, low-grade patients and high-grade patients with rapid calcitonin had no difference in distant metastatic rate. We felt like this was still very powerful because what this translated to in our minds is the grade itself is highly predictive for local recurrence, which would make sense, as well as prognostic for survival. But patients that have rapid calcitonin doubling times may have already micrometastatic disease that's spreading, and so it may be irregardless of grade. So the combination of the two, we felt, would be very powerful in the surveillance period. Those are the major analyses in our study. The limitations include a whole cohort of factors. In particular, this is a retrospective study. And what's a retrospective study? So was the medical decision-making in the past, and the study variables were not very well controlled for. In particular, we did see very inconsistent CEA and calcitonin measurement times that varied by providers that were doing the major surveillance. And this varied by whether medical oncologists were doing the measurements, whether endocrinologists or surgeons were doing the subsequent surveillance. But still, because of the nature of our institution, we had consistent enough measurements to be able to perform the study. And as many of you already know, this is a very, very rare disease. And owing to the rarity of the disease, the cohort numbers in our study were relatively low. We had enough to perform the statistical analyses that we had performed, but there were some other analyses that couldn't be performed, like subset analyses that couldn't be performed just because of the low cohort numbers. And then Ki-67 was missing in about half of the patients in our cohort. We felt like this was less critical as in the other patients, Ki-67 played a role in only one patient converting from low grade to high grade. But that has been one of our study group's objectives, is to try to complete the Ki-67 measurement for the remaining of the cohort, particularly since we'll go on to perform additional clinical studies. To move on to the discussion of this manuscript, right off the bat, I think the most highlighting feature of this manuscript is how rapid the calcitonin doubling times is in high-grade patients compared to low-grade patients, with 90% of high-grade patients having a doubling time less than 2 years, which is significantly greater than 24% of low-grade patients, with 68% of low-grade patients never doubling. Historically, doubling times less than 2 years have been associated with worse recurrence and survival outcomes, and this was re-demonstrated in our paper. And in high-grade patients with rapid doubling times have particularly worse local recurrence and overall survival, as I alluded to in the 2 slides ahead. And this suggests that high-grade patients are particularly more aggressive. So we kind of beg to question, do high-grade patients need the majority of the surveillance? I think a lot of these future implications are pending further studies and pending further societal guidelines and review of the major papers. But it's just, I think in the post-operative setting, I think it's fair to assess for grade and calcitonin doubling times. And based off those values, determine what sort of surveillance strategies or what kind of close surveillance patients will need. In terms of the implications of this study, as I talked to you about previously, is I think across the board, all patients that have surgical resection of medullary thyroid carcinoma should have a pathologic review to grade patients based off low or high grade. And high grade patients should subsequently be followed up with the provider to be able to calculate calcitonin doubling times, as well as to evaluate the additional factors that we use in the preoperative setting, like gender, age, as well as stage, to manufacture a patient-specific surveillance strategy. Surgical resection, I think this is a major additional kind of highlight point, is not necessarily curative for high-grade patients. And these patients need very close surveillance, particularly in the first year, as we noticed that calcitonin doubling times are less than 1 year for most of these patients. And grading biomarker values are important components to try to assess whether patients are high risk versus low risk, and may identify a cohort of patients, particularly those that are of high grade and have rapid calcitonin doubling times, that could benefit from adjuvant therapy trials in the future. So moving from study implications, this study, as any introductory study does, leads to additional questions. And I'll highlight some of the subsequent work we're doing. But the other questions that kind of stemmed from this, at least surveillance paper, was what is the implications of the surgical intraoperative evaluation of patients with medullary thyroid carcinoma? Can grade be assessed in the preoperative setting to assist surgical resection factors, or whether high-grade patients, if they could be identified preoperatively, need a closer evaluation of their lymph nodes? And could we change the surgical management of patients, at least in the post-operative setting, and once the grade is identified? And many of our partners and international partners are working on so many of these very questions. Like we had recently just published a paper on the correlation between RET mutations and grade. But the current work we're doing is to assess whether grade could predict, at least at the time of surgery, germline mutations as well as lymph node burden, and what these subsequent effects on outcomes are. And I'll go through this really quickly because a lot of this is mainly unpublished, but to build off of the limitations in the previous study, we employed the additional patients from our additional sister international institutions including the Royal North Shore, Institut Gustave Roussy, the Emory, the University of Bologna, as well as the Brigham and Women's Hospital. And this allowed us to collect a cohort of about 350 patients and subsequently grade patients into low grade and high grade. As you can see right off the bat, we significantly increased our cohort numbers to 275 low grade patients and 79 high grade patients. And I'll go through this briefly because the vast majority of the study is these results are unpublished, but just to kind of highlight how important I think grade will play in the future of diagnosing and surveillance strategies for patients as well as surgical management of patients is right after we aim to evaluate patients on lymph node burden at the time of surgery, and we use two major factors to do so. Number one, the number of positive lymph nodes, irregardless of the number of overall lymph nodes in a specific compartment, as well as the lymph node ratio. And the lymph node ratio here is the number of positive lymph nodes to overall lymph nodes collected. And right off the bat, you can see that high grade versus low grade patients, high grade patients had significantly worse lymph node burden in any sort of compartment. This was further stratified by specific compartment. And while you can see in every single compartment, high grade patients had greater lymph node burden compared to low grade patients, this was only statistically significant off our prelim analysis in the central as well as the ipsilateral neck. And not only was it significant, it was significant to a p-value of less than 0.001. So this is very, very interesting data, I think, because at the time of surgery, a close evaluation of lymph nodes is kind of begs to be evaluated if we know a patient is high grade. And evaluating RET mutation status, high grade patients, a greater proportion of high grade patients had RET mutations, and this translated to worse disease, as we saw before, in the ipsilateral neck as well as the central neck. And when we evaluated patients based off of high grade and low grade, and whether and based off of whether they had a previous ipsilateral neck as well as central neck dissection, these are confusing graphs, but the red is low grade and the blue is high grade, and the solid line is local recurrence and the dashed line is distant metastatic rate. High grade patients had significantly worse local recurrence as well as distant recurrence compared to low grade patients. And this translated over to overall survival as well, where high grade patients that despite a dissection had worse outcomes. So in conclusion, patients with high-grade medullary thyroid carcinoma are observed to have more rapid calcitonin CA doubling times compared to low-grade patients. And in particular, the 2-year marker is a very predictive value. High-grade tumors predict for worse local recurrence, distant metastatic rate, as well as overall survival. And amongst those patients that had rapid calcitonin doubling times, high-grade patients were associated with local recurrence and overall survival. And so I think the natural conclusion from this manuscript is that high-grade patients that have rapid doubling times should be monitored closely for recurrence and be, in the future, if they are available, considered for adjuvant therapy trials. I want to conclude by thanking my mentors, in particular, Dr. Unch and Dr. Gosain, who were critical in not only bringing this project to fruition, but also establishing the grading system, and Dr. Shaha, Ganley, Spanheimer, Wong, and Tuttle, who have been critical in helping to move this and progress this paper. And if you have any questions, I'm happy to answer them now, or if you wanted to speak separately, I've attached my email here and my mentor, Dr. Unch's email as well.
Thank you, Dr. Nigam, for this incredible presentation and incredible work on the doubling times and tumor grade. We're going to hand the mic over to Dr. Brandwein so we can start a little bit of a discussion, and we'll come back to the Q&A. See if there's some that the audience has sent already, so we'll come back to that after Dr. Brandwein's presentation.
So I want to congratulate the authors for really nice work, which follows on the whole grading system work that is just fairly recent. And I really want to thank you for also sharing further unpublished data, because it's extremely interesting.
Neshma Levy, FaceTime video.
Yeah, that's my granddaughter. Okay. So these are the authors. and I have no conflicts of interest to declare. So the traditional prognosticators for medullary thyroid carcinoma were age, gender, nodal status, stage, vascular invasion, and calcitonin.
National Levy, FaceTime.
And as we've heard, calcitonin levels, particularly the doubling time at 2 years, were predictive and validated prognosticator for patient outcome. So in 2020, the Memorial Group published a very important paper which shows the tumor grading system for medullary thyroid carcinoma. And in that study, they evaluated retrospectively 144 patients with medullary thyroid carcinoma from 1988 to 2018 with an extremely detailed histopathological evaluation. So they did many markers. And so what I'm going to show you is what comes out of the analysis of many histopathological markers. They found a cut point of 5 mitoses for 10 contiguous high power fields. And tumor necrosis is just a binary yes/no, as really the only independent outcome predictors after multivariate analysis when adjusted for known confounders. And that included one-time measurements of post-op calcitonin CEA. Now, in this current paper, the authors tell us that the reason that post-op calcitonin as a single measurement is non-predictive is due to the wide distribution of values. So the current study is really just a necessary outcome of this study. I just to mention, because in terms of the cut point, these authors also evaluated a number of different mitotic cut points, 2 per 10 and 10 per 10. And this is from Ronnie's paper. I just want to show you at low power, which is bottom left, and then high power, bottom right. You can see an example of necrosis, which is fairly easy for pathologists to recognize. The only caveat is we have to make sure we're not overcalling FNA-related necrosis, but there's a schema for that. So it's a nice and robust prognosticator. Well, 2020 was a good year for medullary thyroid carcinoma grading. And here at the same year, there's a group from the Royal North Shore Hospital in Sydney, Australia. They published a much smaller cohort of 76 patients with medullary thyroid carcinoma. And again, they also did a very detailed histological evaluation of all features and outcome. And they too found that there were only 3 features which were predictive of outcome after multivariable analysis. So they looked at Ki-67, and they looked at 3 different cut points that were predictive. And then the mitotic count cut point, they found 3 mitoses per 10 contiguous high power field. They also had examined a cut point of 2 mitoses, and that was not significant, but 3 was. And of course, necrosis was important. Now, these authors had suggested a 3-tiered grading system. And here we see by Kaplan-Meier analysis how, sorry. Okay, so we see here by univariate Kaplan-Meier analysis how the Ki-67 and the mitotic index have impact on prognostic survival. Okay, so already this begs for further clarification, because you want to have a uniform group of features and a validated group of features to recommend for pathology grading worldwide. And so these 2 manuscripts quickly led to the International Medullary Thyroid Carcinoma System, which was published in JCO in 2021. And here they were pooled 322 patients with medullary thyroid carcinomas from 5 centers, the US, Australia, and Europe. And all of the members of the groups evaluated independently all of the features, not just the validated features, and they were blinded to outcome. They looked at the memorial, they examined the memorial schema versus the Sydney schema versus other possible multi-tiered schemata. And again, these three features came out as being independently predictive of outcome. They were mitotic activity, and here the cut point is five or more for 10 consecutive high power fields or 2 millimeters squared, and Ki 67, again with a cut point of 5% or more, and necrosis. And here, when I'm showing you the actual data, of these patients, 25% of the patients were high grade. So that's a number that we've been seeing in all of these studies. Is high grade is just a small percentage of all of these tumors. And on multivariate analysis, the tumors which are defined as high grade were associated with decreased overall survival. Here you have a hazard ratio of 11, means 11 times more likely. Disease-specific survival, 8.5 times more likely. And local regional recurrence-free survival also decreased more than 2 times likely. Well, one question we could ask is, why did it take so long for pathologists to develop a grading system? And I think what Ronnie starts out in his paper says very well is, the overall rarity of medullary thyroid carcinoma has really limited these studies that would find a robust grading system. He points out that necrosis and mitotic activity were also an association with the predominant spindle type of pattern, were in 1966 reported to be predictive of a poor outcome, but there was no real statistics performed at that time. Nuclear atypia is kind of a standard pathology go-to feature. And what I mean by that is the nuclei of cells can look very different from one another, as we see in this picture. But when it comes to endocrine tumors, nuclear atypia is not predictive for either benign or malignant tumors. Okay, so in this study, the question was asked, can calcitonin doubling time further refine the predictive value of tumor grade? And we see here, this is the flow chart that was used. We've already seen this. So they looked at 144 patients. It's the same cohort, but they took out patients who presented with metastases and also patients who had inconsistent surveillance. So the study group was 117 patients. And again, a quarter or less of the patients were basically graded as high grade. And I think this is one of the money slides that was nicely presented. Here we see the doubling time, calcitonin doubling time, cut point of less than 2 years for low-grade patients and for high-grade patients. So first, let's look at high-grade. Everybody who had a doubling time of less than 2 years for high-grade, it was less than 2 years, and there were no long-tailed off doubling times. And there were some patients, few patients, who had never doubled. And of these patients, the majority of them had some evidence of disease manifestation, and a high percentage of these patients died. So high-grade medullary thyroid carcinoma doubling time less than 2 years, 90% manifested disease, and 45% of them ultimately died of disease. I think this is very interesting. For low-grade patients, which is a much larger group, all of the patients who had doubling times less than 2 years, again, a high percentage of these patients had some kind of disease manifestation, and one of these patients died of disease. So this really shows you how the two features interact. And we've seen this Kaplan-Meier, and I'm just showing it to you again. Here, all of the patients who had the calcitonin doubling times less than 2 years are stratified by grade. So these patients are high grade and low grade, high grade, low grade, etc. And what we see here is that the local regional disease-free survival was worse for high-grade patients when you compare the disease doubling time versus grade, and is significantly worse for overall survival. And distant metastasis-free survival actually approached significance, but is not fully significant. So I want to congratulate the authors on very successful work. And I want to start with the first question, which is, of the low-grade patients, because you have a big number of them who had doubling times less than 2 years, were there any other predictive features that could explain why they did have this course?
Yeah, so for the low-grade patients, I think it's very interesting. So we did look into other factors. Like we did a whole multivariate analysis to evaluate. Like in my slides, we just highlighted.
Yeah.
We highlighted grade and calcium dung times, but we had done an additional multivariate analysis, and we included factors that had been previously predicted by Dr. Ganley's study group, including gender, age, and stage and nodal involvement at time of surgery. And while compared to high-grade patient, the high-grade variable, these were still significant, but when compared to high-grade disease or rapid calcitonin doubling times, these additional factors were far and away less predictive compared to grade and rapid calcitonin doubling times. Now, the caveat here is that the significance of Dr. Ganley's study is that it looks at preoperative factors that can be assessed right off the get-go. The limitation with our kind of study is that these can only be assessed in a post-operative setting. So at least in the post-operative setting, our factors of calcitonin doubling time and grade are far and away more predictive of any additional factors. While they play a role, they're the most critical, I think, in the post-op setting. But when you're planning for surgery and we're trying to get grade to the preoperative setting, it's very difficult to assess a lot of these factors in the preoperative setting. But if you could somehow predict for these things ahead of time, I know you can't do calcitonin doubling times, but if you could assess grade at least in the preoperative setting, I think that would be like the crux. That would definitely be added on to any sort of nomogram in the future.
Well, in terms of understanding the low risk, the low grade yet poor outcome patient, you do have a fairly sizable in this cohort. So I'd be talking about a subgroup analysis, and you have a fairly large group of 94 patients. So did you do sub-analysis within the group to try to explain why 6 patients out of 94 did have high doubling time? You've adjusted for grade.
Yeah. Oh yeah, so we did do that's a great question, but we did do subset analyses, and as I alluded to earlier, just the number of patients is what kind of held us off from being able to publish any sort of subset analyses because they weren't statistically significant. But when we did compare low grade patients with doubling times less than 2 years and greater than 2 years, I will say a lot of those less than 2 year patients, it seemed like they never had undetectable disease. So there may have been in the initial an already micrometastatic disease present, or a lot of these patients aren't getting their lymph nodes removed. So a thorough evaluation of lymph nodes probably isn't being done in the preoperative setting or even intraoperative setting. So there could just already be micrometastases present within the lymph node itself at the time of it. So I would say 4 out of the 5 patients that had doubling times less than 2 years, they never went down to undetectable disease. And I know you can't use undetectable disease as per se as tumor cure, but it's not unheard of to think that there was unnoticed metastatic disease or micrometastatic disease, at least at the time of surgery in these patients.
I want to ask a follow-up question to Dr. Brandwein's question. So we do find that there's this common worry where we need an early predictor of poor prognosis, and we are speaking about tumor grade as an early predictor of what happens thereafter with the doubling time. But could we flip the coin around? And I know this is going to be a difficult question to answer in this side of the world, but for example, Europe, they use pre-op calcitonin. when you have a thyroid nodule. Could we use calcitonin to predict tumor grade? I think we're looking at pathologists with a microscope, trying to ask them in their microscope, do you see something that might make us worry down the line? But could we help them with something pre-op? Like you mentioned a couple of features, but what about pre-op calcitonin? Do you have any sense of? I understand not everybody does it routinely, but do you have any sense of how calcitonin could work inversely to the tumor grade?
Dr. Brandwein, do you want me to start, or do you want to go ahead and answer that question?
No, you go.
Oh, okay. Well, you know, obviously I'll defer to Dr. Brandwein because I think you are definitely the expert on this. But we've definitely looked at pre-op calcitonin levels and attempted to at least start to answer this question. I think the pre-op calcitonin levels has a lot of challenges. As I showed a chart of the pre-operative calcitonin levels, and far and away, high-grade patients had higher preoperative calcitonin levels compared to low-grade patients, but there's just so much variability, it's just hard to predict. Like some low-grade patients had calcitonin levels in the thousands, but the vast majority of high-grade patients had calcitonin levels in the 10,000s. But I just don't think there's enough work there to try to stratify patients based off the preoperative levels to predict grade and aggressiveness of disease. But I think the other interesting point that gets brought up out of the preoperative calcitonin levels, and I've had some talks with Dr. Shaha about this, is that I would say many of the patients that have very, very high calcitonin levels are patients that have non-encapsulated disease. And I think that plays a very critical role in terms of how aggressive a tumor is. And we're trying to do some initial studies, at least when I get to Memorial, on trying to answer some of these questions. But I will say that almost every non-encapsulated medullary thyroid carcinoma that we've seen has been a high-grade tumor. Of course, this analysis, I mean, this is just anecdotal or stuff that we've had discussions in passing and no formal analysis, but I think pre-op calcitonin speaks to aggressiveness and the level of disease presentation that stays. But Dr. Brandwein, I don't know if you have any additional thoughts.
Yeah, no, I don't have experience correlating pre-op calcitonin, but I was thinking about, you know, can you, what kind of intraoperative assessment can you do to help make a prediction in terms of the lymph node, you know, dissection? I don't think that grade per se. I don't think that looking for necrosis, and I don't think that mitotic activity, in my opinion, can be helpful intraoperatively, because you're dealing with a, well, it's the tumors look different. They're not, if you have it, okay, tumors look different. They're not fixed. Mitotic count would be very challenging on an intraoperative basis. But, you know, looking at something like tumor encapsulation, certainly, you know, you have, let's have a perfect scenario where you know that you have a diagnosis of medullary thyroid carcinoma going in. Because if you don't have that diagnosis going in, you know, you're going to need immunohistochemistry to establish the diagnosis post-operatively. So if you have the diagnosis going in, you could evaluate tumor encapsulation, and it could be very feasible to do some kind of central lymph node count and ratio, and to look to see if that's predictive. That would be tedious but feasible, as opposed to overall grading, which I think is just not going to be feasible intraoperatively.
I'll turn this around on you, Dr. Brandwein. Say we do this lymph node evaluation.
Mm-hmm.
Is it fair to do this intraoperative analysis of lymph nodes on frozens and send it to our pathologists and tell us what is the lymph node burden, what is happening here? Can you predict? I know there are time constraints. Frozens aren't the best for assessing, but you know, how much should pathologists start to get involved with grading patients, at least in an intraoperative setting?
Well, so what we usually do for PTC is some paratracheal lymph nodes are sent, you know, for assessment. I would say that it would be an interesting thought and feasible to do an intraoperative level 6 assessment but not a lateral neck assessment, because there's so many more lymph nodes, and the dissection would take a lot longer, right? But to float an idea of just looking at lymph node ratio in level 6, it's time consuming, but it's feasible. Now, everything has to be balanced with, what's the workflow going on at that time for, for other frozens. So, but that's something that, could be pursued and could be interesting.
Yeah. I mean, it's medullary thyroid cancer is not very common. So the few times that you recognize them, you could get a pathologist that's ready and willing to evaluate
Right.
it.
Well, I think it's still better to establish the diagnosis preoperatively.
Right.
And not wait, and not count on frozen to establish the diagnosis.
Yeah.
So again, what I didn't mention is that medullary thyroid carcinoma can have a wide range of appearances. And Yuri Nikiforov said, it's like the melanoma of the thyroid. It could just look, one case could look so different from the next. So.
By listening to you both and the limitations that we have on analyzing this data and the rarity of the disease, just as the clear rarity of the disease, I think if you agree with me, there's an urgent need to for bigger data, like bigger sets of patients, maybe multi-institutional, like you have been just starting with your partners that you were mentioning before. I want to ask you both, how do you envision the use of data-driven approaches such as data mining, AI analyses, enhancing prognostic models and treatment for strategies for medullary thyroid carcinoma, like gathering big data and then analyzing just to potentially identify those variables that we have not identified yet as prognosticators of poor behavior.
Yeah, go ahead, Dr. Brandwein.
Yeah. Do you mean new variables that we haven't identified yet?
Yeah.
Yeah, I think that's medullary thyroid carcinoma is not going to be that's not a good approach because of the rarity, And I think that there's a number of studies, including the international study, which just looked at a big range of established variables. Plus, they looked at other things like the amount of tumor cells expressing calcitonin, et cetera, the amyloid, like a lot of things. And really, these features, are the only ones that were predictive on multivariate analysis. So I don't think like a big agnostic approach to a rare tumor is going to yield anything. And I think because again, the bottom line is the numbers are so small. And then once you have to really go backwards, right, to get big numbers, treatment is variable.
Yeah.
And you're not going to get Q67, you don't want to go too far back in terms of your diagnostic group.
And I think, Dr. Brandwein, you probably noticed a lot better than I do. I think there's a lot of even provider to provider variability itself. So for AI to develop algorithms based off of previous studies, I think it's going to be less accurate because there's already a lot of controversy and less agreement on some of these, very factors.
Right.
In this study, we had to sit down every single pathologist, and they had to literally be on a Zoom call, and they discussed every single slide together to try to establish this grading system.
Yeah.
So the beauty of this grading system is in its simplicity, and so you can't beat simplicity.
Yeah, and like they say, like with all of this new technology coming forward, the AI enthusiasts, they always use the term GIGO, garbage in, garbage out. So you have to be careful with what we use. Totally understand. We're about to hit the 9 o'clock hour here. I don't know if you will have any final insights or any things that you would call next steps on your research, additional to what you've mentioned, or if you had a chance, Dr. Brandwein, what would you ask? What would you think is the next step in this field, in research in medullary thyroid cancer prognosis?
Yeah. From my perspective, and I'll obviously defer to Dr. Brandwein after this, but I think I've already alluded to some of the follow-up questions, but I think the main thing out of this manuscript is just more and more institutions have to start assessing for grade. It's a novel grading system and change is hard. But I think, as Dr. Brandwein alluded to, this is a simple grading system that can be assessed, on the pathologic specimen of every single resected specimen. So the more institutions that are evaluating grade, getting more comfortable with assessing low grade versus high grade, translates to better clinical surveillance or developing better surveillance strategies that can then go on to change some societal guidelines or how we view medullary thyroid carcinoma. Because in my opinion, there's just medullary thyroid carcinoma. There's no benign medullary, there's no malignant medullary, there's no highly aggressive medullary. So I think these are the follow-up studies that if we have more and more institutions and pathologists and providers recognizing and using it, the more powerful it becomes.
Yeah. I want to make a comment in your manuscript. You and in this talk, you mentioned about how for high grade patients, this kind of surveillance of calcitonin doubling time is extremely important. It seems to me that one of the conclusions of your study is that calcitonin doubling time is important for everybody, regardless of stage, because of these, 6 low grade high, patients with high short doubling times. I would like to see more study on those 6 patients, and I would like to see more studies, on low grade patients with short doubling times to see, is it in fact due to your hypothesis that it's undetected disease. I think that's very interesting, and it can lead to better maybe pre-op or better surgery. Yeah.
Especially since we have the international cohort now. So I think that's very powerful.
Well, looking forward to those results, honestly. I want to thank you both for so much for carving out some time this Friday to share this with us and to create just a wonderful discussion. I want to thank all of our audience for being here with us. And I want to invite everybody to come back with us next Friday. We're going to have Tumor Board with Dr. Mike Tull moderating, and cases presented by Dr. Rosella Alice. So we're looking forward to that. I hope you all have a great weekend and stay safe.